Now we are starting our ASNM 5th Rising Nuclear Medicine Professional Challenge, Session 1. So the first speaker is from Myanmar. Her topic is first experiences of theranostic of prostate cancer in Myanmar.
So 12 minutes presentation and 3 minutes Q&A. So I will push your bell last 1 minute.
Hello, good morning again. I'm Dr. Thuri Jivu from the Nuclear Medicine Department of the Mandalay General Hospital from Myanmar. Today, I would like to present about the first experience of theranostics of the prostate cancer in Myanmar. This is our country, which is situated between the very large country of the China and India. The population of our country is about 50 million. Epidemiology of the prostate cancer. Prostate cancer is a growing cancer in global epidemiology and leading the cause of the cancer death amendment with population aging and population growth. Prostate cancer is the second most common cancer in men worldwide and also the fourth most cancer overall. Prostate cancer becomes an important public problem not only in the Western countries but also in emerging malignancies in developing nations like as our countries. Incidence and mortality rate vary significantly depending on the geographic region and population. In our country, the incidence of the prostate cancer is about 4.3 per 100,000 population and also the third most cancer in men of old age. Management of the prostate cancer in Myanmar. Currently, serum PSA level is the marker of the choice with highest predictive value in prostate cancer management. Regarding to the stage of the disease, ultrasound, CT, MRI, and 99-MTC, MDP bone scan are the choices of investigation which are practicing in our country. The following standard treatments are for clinical localized prostate cancer in our country: active surveillance, weight waiting, radical prostatectomy, radiation therapy, and hormonal therapy. And other treatment options for those who fail initial therapy, we can proceed androgen deprivation therapy and chemotherapy. Theranostics for the prostate cancer. Targeted radionuclide therapy is rapidly developing therapy option for advanced prostate cancer management. PSA is an ideal target for the theranostics of the prostate cancer because it is mainly expressed on the surface of the prostate cancer cells and its metastatic counterparts in all stages. Evidence-based success of the gallium PSMA and lutetium PSMA theranostic already promised that in management of the prostate cancer worldwide, in gallium-68 PSMA PET-CT plays an important role in the diagnosis of the prostate cancer. In our country, although PET-CT and F-18 producing cyclotron is running at public hospital, Yangon General Hospital, gallium generator is still out of reach because of the budget in the health planning. Therefore, 99-MTC PSMA I+S followed by lutetium-177 PSMA theranostic in prostate cancer with PET-CT launched in our country, Myanmar. So this is how we label the PSMA I+S peptide. Labeling 99-MTC PSMA I+S is high specific PSMA tracer for SPECT imaging and accumulating in the primary metastatic lesions of the prostate cancer. So we use the primary PSMA I+S peptide labeling. And then we label with the 99-MTC PSMA, PSMA I+S with the 99-MTC. 5 hours after intravenous injection of the 99-MTC PSMA I+S peptide, SPECT imaging was taken. Because PSMA expressing tumor show continuously increasing strong accumulation over 5 hours. And then we compare the 99-MTC PSMA I+S image with the gallium PSMA image, which taken at abroad. One particular patient as follows. This is the image of the 99-MTC PSMA I+S PET-CT. We can find abnormal accumulation of the radiotracer update are seen in both shoulder regions, more intense on the right shoulder region, and some vertebrae, and also in the primary side. This is the Gallium PSMA PET-CT imaging which taken at abroad. Also, we can find abnormal FTG accumulation also find at the both shoulder regions and many vertebrae. And then we use the 177 lutetium PSMA. And in the to label the 177 lutetium PSMA, there are two contacts from the commercial kit, PEPFAR and peptide. How we do the 177 lutetium labeling with the peptide? We mix PEPFAR. We add the PEPFAR to the peptide, shake well, and then peptide PEPFAR mixture labeled with the 177 lutetium 0.4 mg and heated at the 95 degrees centigrade for 30 minutes under the lead sheeted heater. And then shake well every 10 minutes for 3 times during heating, and then cool down to the room temperature. Now it's ready to use. 177 lutetium PSMA administrations, patient preparation. We explain the procedure and receive written consent every time. We treated the outpatient setting. We use the 6 to 8 gigabecquerel per patient and 3 doses with the interval of 8 weeks. 177 lutetium PSMA is given by slow intravenous injection 15 to 20 minutes in a volume of the 50 ml, diluted with the 0.9% sterile sodium chloride, followed by a flash of the sterile 0.9% sodium chloride. Patients are hydrated with the pre and post therapy with 1 to 1.5 liter of the ring-latex solution and are encouraged to wipe as soon as possible. And then later, 24 hours post-therapy PET-CT whole body imaging was taken. After each dose, we check the hemogram, total, free PSA, urea, and creatinine level. This is the imaging of the post-therapy 177 lutetium PSMA imaging. We can find the accumulation of the radio tracer update of both shoulder regions, more intense at the right shoulder regions, many vertebrae, ilion, and also in the primary side. We studied the 4 patients of the metastatic castration-resistant prostate cancer, hemoglobin percentage and PSA levels, total PSA levels of the study patients individually. There were bone metastasis, soft tissue metastasis, and bone pain in all cases. After the therapy, we find that 2 patients, second patients and fourth patients show PSA level is reduced significantly after the therapy. But in first patient and third patient, their PSA level were increasing after each dose of the therapy, and moreover, hemoglobin percentage is were reduced. And the significant one point is there were no bone pain at all after the doses of the therapy. In the point of the cost effectiveness, Gallium PSMA imaging will cost more than $1,000. It will be 15 million jets in Myanmar jets. 99 MTC PSMA will cost $250. It will be 35,000 jets only. Moreover, Gallium 68 PSMA is not feasible, and 99 MTC PSMA is easily available for routine practice. So, according to our study, there were no serious adverse and significant changes in WBC count, liver function test, and renal function. Well, we found that same effect on the hemobiotic system in this small study, reduction of the hemoglobin percentage and platelet count. Therefore, blood transfusion were needed in 2 cases with the extensive skeletal metastasis. Remarkably, free of bone pain and improved in the quality of life is noted, and we found that 50% success rate in this small study. 2 patients with extensive skeletal metastasis show raised PSA level significantly after each therapy. There may be need more dose of blur phenomena. In this point, it also can be explained by the heterogeneity of the PSMA receptor activity within the tumor population, so that some sites will not respond to the treatment and will manifest as the disease progression. I would like to conclude, this pilot study is the stepping stone of the diagnostic nuclear medicine in Myanmar, our country. 99 mTC PSMA I plus S is comparable with the Gallium 68 PSMA. 99 mTC PSMA I plus S imaging is safe and cost-effective for the developing countries without PET-CT and Gallium 68 imaging facility. We haven't received any financial support from the radiopharmaceutical company. We would like to appreciate our patients. Without their support, as we couldn't have the opportunity to land the diagnosis in prostate cancer. Thank you.
Now, paper is open for discussion. Only 1 or 2 questions because we are having only 2 minutes. Any question? So thank you very much for your paper.
The second presentation is iodide 131 MIBG treatment in relapsed refractory neuroblastoma from Dr. Yok Anung Nupon Jo Sakuro. Please.
Okay, ladies and gentlemen, I'm honored to be here as a representative from Thailand to present iodine 131 MIBG treatment in relapsed and refractory neuroblastoma in Thailand, which is totally based on our hospital experience. Okay. Before I further get down on the details of my study, I would like to present the background and rationale behind this. So let's get started with the basic structure of MIBG, which stands for meta-iodobenzylguanidine. It's the combination of 2 archive drugs that we no longer use anymore in clinical practice. They are beryllium and guanethidine. Basically, both of them inhibit norepinephrine release from nerve terminal. So that's why they had previously been used in patients with sympathetic overdrive, such as hypertension or arrhythmia. But like I said, we don't use them anymore clinically. So we just pick some part of them to make MIBG. So that is benzene group on beryllium, which has bromine here on the ring, and guanidine group of guanethidine, which is our group. Basically, bromine and iodine, since there is share some chemical properties in common, since they are halogen on the same row of periodic element table, as you can remember from high school. So we just simply replace bromine. I cannot scroll that, sorry. So we just simply replace bromine with stable form of iodine 127 at the meta position or the second carbon position away from the R group. That's the word M in meta in MIBG from. At this point, we get iobenguane or cold MIBG, which is not yet radioactive. The next step, we just exchange iodine 127 with iodine 131, which is radioactive. I really need to explain this because during the radiopharmaceutical preparation, we create approximately 1 molecule of hot MIBG or radioactive MIBG per 2,000 non-radioactive MIBG, which is create something called impurity and might be potentially adverse reaction during the treatment that I'm going to explaining in a few more minutes. The treatment is classified as targeted therapy. As the MIBG join the tumor cell, it's time for real hero iodine 131 to do their job by emitting beta ray, which has energy about 0.6 MeV and has a range in the soft tissue about 1 centimeters. The concept of tumor eradication is not only direct tumoricidal effect on target cell, but also indirect effect. Suppose we have 1 molecule of iodine 131 MIBG here, just hit the first cell. Okay, beta ray from iodine 131 just radiate and kill the first cell. As I mentioned earlier from the previous slide that iodine 131 has the beta range about 1 centimeters, it still move a little bit further and kill the cells along this path. This is crossfire radiation. So let's get back to the first cell that was hit earlier. It released some kind of mediator like cytokine to induce apoptosis or death by surrounding cell. This is bystander effect. So this is the general approach of neuroblastoma treatment in our hospital. We usually start with induction chemotherapy for at least 4 cycles, then go on surgery in operable cases. Regarding chemotherapy formula, I'm more comfortable to leave this part with pediatric oncologists. Based on our hospital formulas, the role of MIBG in cases of planned for stem cell transplantation is usually after induction chemotherapy and surgery in order to eradicate tumor cell in bone marrow. However, in case of unable to go on stem cell transplantation, the role of MIBG is almost always palliative treatment, alternating with maintenance chemotherapy and radiation therapy or systemic treatment and other. If there is at least stable or improvement of disease without significant hematologic toxicity, repeat MIBG treatment is reasonably provided. We would like to review our refractory and relapsed neuroblastoma patients treated with MIBG in our hospital in terms of toxicities, overall survival, and to see whether there is any factors attributable to survival. So since the study is retrospective and the number of the patients is not quite large, so therefore I humbly prefer to discuss the relevant information along with the specific results. We have 22 patients with mean age around 4 years old. Male and female appears proportionally similar in number. Most common presenting symptoms were palpable abdominal mass. Neuroblastoma is the most common extracranial solid tumor in childhood and have the propensity to metastasize at the time of diagnosis. Our study confirms that metastasis at the presentation of more than half of the patient, most of which are bone and bone marrow. The mean cycle of treatment is about 4 sessions. The average dose per cycle is around 140 millicurie, and the mean cumulative activity is around 480 millicurie per patient. We clarify the rates of each patient in individual profiles, including final outcome. As you can see, it's a little bit overwhelming and too tiny to concentrate each row, right? I will present some of these relevant information as the following aspects. We found disease progression in 15 patients after receiving the at least 1 cycle of MIBG therapy, all of which eventually died. Kaplan-Meier analysis show 5-year overall survival about 37%. The total survival rates show about 15% approximately up until now. As you can see that we access a post-treatment scan in terms of Curie score after first and second treatment consecutively. I'd like to clarify further what Curie score has something to do with survival in our study. Before knowing the abnormality, we consider a normal pattern of MIBG distribution, including salivary glands, heart, liver, GI tract, kidney, and urinary bladder. Most of the time, we can see adrenomedullary uptake, which is compensatory physiologic, provided that there is no corresponding anatomical abnormality. We visually evaluate the uptake and semi-quantitatively assessed by Curie score system, which divided body into 10 anatomical sites, 9 for skeleton, and the other region for soft tissue, grading into 4 categories. So we have 10 locations and total maximum score of 30. Currently, we use CAS score for surveillance follow-up and prognostic evaluation in high-risk patients. For example, if we find 75% of CS score decrease after the induction therapy, this might imply significant improvement in terms of survival or even free survival. This sample's image is a treatment scan of 8-year-old neuroblastoma boy with widespread bone metastasis. We submit the score from each region to be 15 out of 30. As compared between post-treatment scan of the first and second cycle of MIBG treatment consecutively, our study showed no death in all patients with decreasing score. 4 of them review objective responses, either stable or complete remission. On the contrary, all patients with a rising Curie score, no matter how much, show disease progression and eventually died. The univariate analysis model with hazard ratio review patients older than 5 years old have more chance to die 4 times than the younger ones. We also found that the session of MIBG treatment more than 3 or cumulative activities of more than 400 millicurie show prolongation of survival. Also noted from our study, the patients with bone metastasis almost have the statistically significant late survival than the ones without bone metastasis. But by the way, the number of patients is minimal to reach any statistic significance. In relapse or refractory cases, the overall survival is still unsatisfactory, despite multimodal therapies. However, several studies using MIBG as a maintenance monotherapy shows a response ranging about 20 to 60%. The response is a little bit higher in case of less previous treatment. These might relate that to patients tolerate well to toxicity, and less previous treatment literally means less aggressive disease, hence higher response as well. Repeat MIBG treatment is possible, but always limited by hematologic side effects, particularly in high-dose regimen and short period between 2 sessions. Some studies shows well-tolerated response to high-dose MIBG in about 100 days of the 2 consecutive courses. In our practice, we accept around 2 to 4 months of repeat treatment. In our study also confirms the most common hematologic adverse reaction, which is thrombocytopenia. The lowest platelet count is about 6 weeks after treatment. Therefore, we didn't prescribe the repeat treatment sooner than 8 weeks. Hematologic toxicity is by far the most common adverse reaction, especially thrombocytopenia. This appears to be more pronounced in patients with prior myelosuppression from previous treatment, high-dose MIBG administration, or in case of widespread bone metastasis. The common immediate adverse reaction after treatment include temporary nausea, vomiting in the first few days, which is attributable to acute radiation toxicity to gastrointestinal epithelium. By the way, we prophylactically give ondansetron prior to MIBG injection or around the clock to symptomatic patients. As I mentioned earlier from the first few slides about the radiopharmaceutical preparation process, there are many cold or unlabeled MIBG during the process, which can cause spontaneously flushing, headaches, or dizziness. Most of the time, they are mild and spontaneously resolve. Only observation and slow rate of injection is possible. Speaking of the administered radioactivity, there is no current standardized regimen. This is usually based on many factors, such as age, risk underlying disease, previous myelosuppression, or organ dysfunction. To simplify, the dose can be classified as high or 12 to 18 millicurie per kilograms, or low as not more than 5 millicurie per kilograms. High dose is reasonable for curative treatment, but the myelosuppression is also obvious. So we always need subsequent stem cell rescue. On the other hand, low dose appears to have lower objective response, but pain reduction can be achievable. Therefore, we usually use low dose for maintenance therapy for palliative purpose. Due to limitation of radiopharmaceutical preparation in Thailand, the maximum radioactivity dose cannot be exceeds 150 millicurie at maximum. On the basis of high versus dose regimen, the patients with 10 kilograms body weight receiving 150 millicurie can reasonably classified as high dose treatment. On the other hand, prescribing 150 millicurie in 30 kilograms of patients is presumably low dose approach. Okay. Although MIBG treatment has been well established for a couple of decades so far, there is no still standardized therapeutic protocol. The regimen is highly variable in terms of appropriate patient selections, administered dose combination with other treatment modalities. Is always the case in developing countries like Thailand to optimal the appropriate setting for such treatment. Besides the intrinsic limitation of a retrospective study of our study, the potential issue is the number of population is not very large, which is relatively small to reach any statistically significant. Thank you for your kind attention.